Good evening, everybody. مساء الخير. We are going to start this webinar about basic principles of primary ocular trauma management. We are very happy to have Professor Mahmoud Suleiman and Professor Tamer Gaudat. Each is an expert in his field, and I'm thanking them for being with us. The idea of this webinar is that we want to tackle the basic principles for the junior staff or whoever is dealing with emergency and the cases and trauma cases in the ophthalmology. And if we succeed to transfer the principles of management of each of the most common cases that we see, from lead injuries, corneal scleral lacerations, traumatic cataract, and intraocular foreign bodies, because these are the most frequently seen cases in the casualty. So we hope we can convey the message of the principles of management, how to evaluate the cases, how to ask for investigations, how to proceed, when to do the surgery, the sequence of surgery, the principles of and the techniques, types of material we need. So all this will be answered hopefully during this symposium. So we'll move on with Professor Tamer Gaudat, Professor of Ophthalmology in Cairo University, and one of the best oculoplastic surgeons in Egypt and maybe in the whole area of the Middle East. So Professor Tamer. You can share.
Unmute, yeah. Unmute Tamer. Yeah.
Okay, thank you so much, Dr. Yahya. And okay, I can share now my screen. All right.
We'll try to raise your voice, right, Dr. Tamer.
حاضر. Okay, كده my screen is shared كده.
It is
تمام.
shared. تمام.
Okay, thank you, Dr. Yahya, for this kind invitation. And actually, I am honored to be with my professors and at the same time my dear friends, Professor Dr. Mahmoud Suleiman and Professor Dr. Yahya Salah. Actually, I started my professional career when I was a resident many years ago with them, and actually with their guidance and their support, I reached a lot of things. Actually, I thank them. I thank them for being there with me all the time. And today we'll speak about the eyelid injuries. Okay. First, we have to know the types of eyelid injuries. Of course, this course is a basic course, so I will try to do my best to make it simple as possible. But the main idea of this lecture is to give the science behind the lead injuries and how to manage lead injuries. So you have to know a lot of things before managing lead injuries. So first of all, you have to identify the type of lead injury the patient has. Is it a simple lead injury? Is it superficial or deep? Superficial, I mean, is just skin, like skin scratch, so you can just put a steri strip and follow up the patient. Or is it full thickness skin reaching the orbicularis oculi muscle? Or is it even deeper, cutting the orbital septum with orbital fat outside the wound, or even the levator and other structures? Or the other group of lead injuries is complex lead injuries, which is accompanied with ocular injuries, for example, rupture globe or hyphema or corneal wounds, any ocular injuries, or even lacrimal injuries affecting the canaliculi, the sac, lacrimal gland in some cases. Is it associated with facial injuries, orbital, and bones? So this is the simple lead wound. As you can see here, this wound is simple. You can see the cursor. The cursor is seen. Okay. So this lead wound is a simple lead wound. Actually, it's very easy to manage because it follows the crease and it's just affecting the skin and even the muscle. Maybe here it is wounded, the orbicularis oculi muscle, but the rest of the wound is just like a scratch. So this type of wounds is very easy wounds. It is a very easy wound. sometimes you think the wound is a simple wound and it's a superficial wound, but when you examine the wound and try to open the wound gently, you will find that it goes deep to the orbicularis oculi muscle. This wound should be sutured in a proper way so as not to leave a bad scar. Wounds, more complicated wounds, like you can see now, this is more complicated wounds, and more deeper tissues are affected here. And actually here, as you can see, the lower eyelid is totally avulsed from the medial side. So here, the medial side, all the eyelid is avulsed from the medial side, and you can always see in avulsion of lids, like the other picture here, that the whole lid is avulsed laterally, and this is the weak point. The weak point is between the tarsus and the medial canthal tendon. This is a weak point, and it is cut here because the tarsus is very tough fibrous tissue. It is not easily cut, but the tendon is a little less fibrous, so it is easily cut here when in this medial part. And actually, we know that here there is the start or the beginning of the lacrimal system. You have the punctum, the canaliculus, so you have to be sure whether the canaliculus is cut or not to manage later or during the surgery. The upper wound here is a simple wound, but this is not a simple wound. So you have to know the rules, which I will tell you now. Sorry for such pictures, but I have to show you that sometimes the wounds is not only in the lids. The wound could be in the brow. As you can see here, this patient has two brow wounds, deep wounds, and also in the other eye here, also the brow is totally macerated with the upper eyelids, very deep wound. You can see the bone here, the orbital bone. Also, she has a facial wound. Of course, since you will deal with trauma and you will deal with lid wounds, you will not choose your patient. Sometimes you have a patient like this. You will not tell the patient, I will do only the eyelid and I will not do the brow or the forehead. I will not do the facial wounds. So you have to know all the rules and the principles of surgery that will give you the solution for all these different types of wounds: superficial, deep, forehead, brow wounds, and so on. Of course, you have to examine the globe. This eye is self-eviscerated eye. So you have to know that this eye is a lost eye and it's self-eviscerated before doing the surgery. What about the canaliculi? Not because the eye is self-eviscerated, you will ignore the canaliculi, because if there is tearing after reconstruction of these wounds, the patient will come to you many times complaining of tearing, and also she can get dacryocystitis and everything will as if there is an eye. So don't ignore the lacrimal system if the eye is lost. This patient, for example, he did first aid surgery. As you can see here, all the wounds are strangulated with very bad technique of suturing the lids, very bad sutures. All this will leave a very bad scar. So he came for another opinion to start to reconstruct all these wounds. And I will show you how to reconstruct such deep and complex wounds involving more than a part of the face, more than a part of the face. So first of all, you have to examine not only the eye, ocular and facial. Sometimes you need to examine the patient under anesthesia, because sometimes the patient comes to you in a severe pain, panicking with his family or with his friends, and you cannot examine the patient in a proper way. So you can tell the patient, we can examine under anesthesia, and then we will consult his parents, for example, or his family, or even the patient himself. You can tell him, we found under anesthesia 1, 2, 3, and we have to deal with such and such and so on. CT is very important, because CT will show you here. CT will show you a lot of data about the bones. Is it if there is any blowout fracture, is there is any foreign body, as we will see later. Anesthesia, as you can see here, the diagnosis of self-eviscerated eye is 100% diagnosed, and the cut canaliculus upper and lower canaliculus, totally avulsed eyelids, of course, and the wounds, the rest of the wounds. This patient, he was refusing examination without anesthesia, and under anesthesia, I found his globe was okay. He had some hyphema, subconjunctival hemorrhage, but there was no rupture globe. So this is very important to know before surgery. As you can see here, the CT, because some patients comes to you with severe hematoma. As you can see here in this slide or CT, severe hematoma, you cannot see what is behind. And don't try to do the surgery. Not because there's a wound and there's some bleeding, you the operating room, don't get the patient parents or the patient will
تامر الصوت فيه مشكله شويه دكتور تامر. اعتقد دكتور تامر فصل الكونكشن بتاعه، اتفصل. هو دكتور محمود انميوت، انت لو عايز دكتور محمود انميوت.
يس
دكتور تامر رجع اهو انميوت. دكتور تامر، دكتور تامر.
Okay, you can hear me now?
Yes.
You can hear me يا دكتور يحيى؟
الصوت واضح.
Okay.
Okay.
تمام. Okay. So as you can see here in the seat. Okay. Shall I continue?
Yeah, please do.
Okay. So as you can see here in this CT, this is an axial CT. As you can see here, this patient has ethmoidal blowout fracture. As you can see, the ethmoid bone is totally fractured, which is the medial wall, and the eye is avulsed. Actually, the optic nerve is avulsed, and the eye is pushed backwards into the orbit. This eye is a lost eye, and this patient will not see with this eye because the optic nerve is avulsed here, as you can see, and the total fracture of the medial wall of the orbit. This patient, for example, you can see here fracture not only of the medial wall but also the floor. So when you do the CT, always ask for axial scan, coronal scan, and take a thorough look to every cut, because sometimes in one cut only you can find here, as you can see in this patient, a foreign body deep into the orbit. So the patient has a very small wound, as you can see here, but there is a foreign body inside. As you can see, this foreign body is outside of the eyelid here. So you have to examine the CT properly to see if there is any associated foreign bodies, because if these foreign bodies are neglected, you will get a fistula and you will get orbital infection, orbital abscess, and so on. So what is our goal in lid injuries? The first thing is to restore the lid structure, and the second important thing you have to put in mind is to restore the function. So not only the lid structure, you have to think about the function of the eyelid. You need to do the sutures so as not to affect the function. And also don't forget the aesthetic look, because the patient will blame you for any scars in his lids or face. So for example, this patient, he had a simple lid wound, but it was a deep lid wound, and as you can see after surgery he was not happy because
تامر هي الصوره مش قدامنا، احنا قدامنا السلايد بتاع الجول. او ممكن دكتور تامر ممكن تجرب تقفل الكاميرا، يعني تشير السلايد ونشوف هل لو انت قفلت الكاميرا ده هيخلي احسن ولا لا.
اوكي.
يعني نحب نشوفك طبعا.
هو كده السكرين شيرد اوريدي ولا لسه؟
كده كويس قوي.
طيب ثانيه واحده انا هقفل الكاميرا. اوكي.
اوكي كده اتفضل يا دكتور تاني.
As you can see here, this patient was not happy with this surgery because he had a very bad scar, and he was not happy at all with his eyelid contour and with the scar in his eyelids. He said to me that this wound was very superficial, as his doctor said, and why it has this bad scar and this bad contour. So you need to do the surgery and avoid such thing. Also, this patient had a cut in the lid margin, and because of bad technique of management, as you can see here, there is a notch in this lid margin. So she's not happy, although it's very, very minimal, but she is not happy of this unsightly notch here. So she came for correction of such thing. This could easily, you can avoid such complications if you do the proper suturing techniques and you follow the proper rules. Also, this patient, he had complex lid wound. As you can see, the lid wound, the upper eyelid here was avulsed and it was not corrected in a proper way. So he has this notch, big notch here, affecting the tear. And this is very important. Don't underestimate the upper canaliculus, because sometimes a lot of residents, a lot of us, sometimes we underestimate the upper canaliculus and think that the main duct for drainage is the lower one. No, this patient has a normal lower tear duct and the upper one is cut, and you can see here a very high tear film, and he's unhappy. And of course, unsightly scars in the forehead, and you can easily do this without all these scars. So you can see here also very bad scars from very improper suturing of the lid wounds and the brow wounds. You can see here the brow, it is totally damaged because the suturing of the brow was very bad technique. The same here in this patient. This patient had a blowout fracture which was not diagnosed during surgery. So the patient didn't correct the blowout fracture. So he has enophthalmos plus very bad scars. I'm showing you these pictures to know how to manage from the start to avoid such complications. So first, the principles of surgery is to know anatomy. You have to know that the eyelid is the upper or the lower eyelid has a certain configuration. As you will see here, the upper eyelid in adults covers almost 2 millimeter. In kids, it is not covering 2 millimeter of the cornea. It is almost on the limbus. Also, you have the lower eyelid, as you can all know and see, it is tangential with the limbus. The lateral angle is a little bit higher than the medial angle. So don't put, if there is a cut here, don't put the lateral angle on the same level of the medial angle. And it is higher also in females more than males, about 1 millimeter. You can see also the crease. The crease here, it is about 8 to 10 millimeter in adults and 6 millimeters in children. So putting everything back to normal is very important to get lid structure in a normal and to get a function, good function and a good aesthetic look. This will show you a very important layer which is underestimated, which is the orbital septum. As you can see here, the orbital septum behind the orbicularis. If the wound is deep wound and this orbital septum is cut and you can see fat, orbital fat coming out of the wound, you have to deal with this fat and with this orbital septum. Don't take your sutures blindly and take the orbital septum. This is what happened in the picture you saw of the bad contour of the upper eyelid, and I will show you how to manage such thing. This patient, as you can see here, because the orbital septum, which covers the whole orbit and behind the orbicularis oculi muscle, was entangled with the sutures. So you have this scar, bad scar, and because it is not sutured in layers, because you have to suture the skin and the muscle differently, and either to extirpate the septum and cauterize the orbital fat to push it backwards into the orbit, and not to entangle these fat and orbital septum in the suturing of this wound. It will give you this result. So very simple step. If you avoid it, you will not get this complication. Also, you have to know that the medial ligament has a superficial band and a deep band. It is not only the superficial one, which is anterior to the anterior lacrimal crest here. You have a very important band of the medial canthal tendon attached behind the sac to the posterior lacrimal crest. So I want to know if this patient has medial canthal tendon injury. Is it superficial or deep? How can I know this? You will see now very soon in the pictures how you can diagnose such thing. The second thing you have to be ready is the kind of sutures and needles, and also the instruments. Don't go to do such surgery just with the needle holder and fixation forceps and that's it. You will need a toothed forceps, fine toothed forceps and a fixation forceps, different scissors, viscot, the NAS also. You will need a lot of instruments like for example the rack اللي هي الشوكة اللي بنشد بيها الهوكس and so on. Sutures, you have to know that sutures could be absorbable or non-absorbable sutures. طبعا in our facility, usually the absorbable suture is the vicryl suture. The vicryl is either polyfilament or monocryle. The monocryle even is much better and stronger for closure of subcutaneous tissues and skin more than the يعني polyfilament. And the idea about vicryl that it initiates some sort of inflammation in the tissues that make it fibrotic and make it heal quickly. So when to use the absorbable and when to use the non-absorbable. The non-absorbable, of course, the silk, nylon, prolene. Silk is the best tying suture, but 10% of patients will have some sort of allergy from silk. So sometimes we prefer prolene, and it's very readily available in all facilities and ORs. You can use it easily, the prolene. So silk and prolene, you can use it especially if you are suturing the periosteum or you need to do a lifting suture. For example, the lateral canthal tendon to the periosteum, you can suture it with the prolene. Also, the medial canthal tendon, if you want to resuture it, you can resuture it with prolene because this is lifting sutures and you need them to be forever. The type of needles, and this is also very important. When to use the cutting, the reverse cutting, the taper, the spatula. The cutting needle, you can use it in the subcutaneous tissue. But the reverse cutting and taper, this keep it for the skin. So if you have a cutting needle like this one, this cutting needle, you can use it in the subcutaneous tissues. If you are also attaching these subcutaneous tissues to the periosteum, you can use this cutting needle. It is very easy to do this with the cutting needle. Keep the reverse cutting and the taper for the skin because they don't do these tracks that could even later make a lot of complications and leave these spots on the skin of the suturing needle. So use the reverse cutting and taper for the skin mainly. But what about the spatula? Don't use the spatula needle for the skin. The spatula needle, you will need it only for the tarsus reconstruction. So keep those for the skin and the spatula for the tarsus and the cutting for the deeper tissues, subcutaneous tissue and the periosteum. The third thing, the surgical technique. So before doing surgery, you have to know anatomy, you have to be ready with the sutures, needles, instruments, and then you go to the surgery. So what to do? What is the main principle of surgery? The main principle is to approximate tissues rather than strangulate tissues. And I'm bringing this picture because here you can see the strangulation of the tissues. As you can see here, all tissues are strangulated. So these sutures should be removed and you have to approximate tissue. How can we approximate the tissues? You have to suture the deeper layers first. Which type of needle? The cutting needle. which type of suture, absorbable or non-absorbable. You can use here the non-absorbable sutures like the Vicryl, but when it comes to the medial canthal tendon or lateral canthal tendon, it's better to use the non-absorbable like Prolene. Of course, you have to clean the whole wound with antiseptic or antibiotic solution, and as I told you, close it in layers to avoid any scarring later. We have simple sutures in simple wounds, but we have also rules for simple sutures. As you can see here, if you are doing just a simple suture, you have to take the bite, as you can see it here, it involves the whole skin. Don't go with the needle and come out here. You have to go to the whole skin, and the volume you can see here should be equal to the volume on the other edge of the wound, as you can see here. So you are taking deep bites and equal volume. You can see here the equal volume of tissues. This is very important in the sutures to do eversion of the lead wound here or the skin wound, as I will show you now. This is another kind of suture which is very commonly used in the margin of the eyelid, the vertical, the mattress suture. The vertical mattress suture, you start far. This is the wound in the margin. And so you start far with your needle, you go deep into the tissues, and you go out here far. Then you take the needle again in the near point, near the margin, and you go out also near the margin. Then you suture your wound. This will evert the lead margin and keep it everted to avoid notching of the lead margin. This is another type of suture, which is far, far, then near, near. This is the kind of suture in the brow. So you will go here, as you can see, from near, then you go out far, then you go here far, and you go out from the other wound at the near part. At that time, you are closing all tissues, the superficial and the deeper tissues, and this is very important suture in the brow. Once you do this for the skin, as you can see here, the skin is everted. This will never bring a scar except in very rare cases. This scar, you will never see this scar or this wound again, because the lid when it heals, it goes down, it goes deep into the tissues. So when you leave it at the end of the surgery everted, as you can see here, you will never see the scarring. As for example, this wound, this patient had surgery before here, and the wound is closed in a very bad technique, so you can see a very bad scar here. And of course, the deep tissues were closed. So the deep tissues, you can use 4-0 or 5-0, and the skin you can close with 6-0 or 7-0. So let us go to the tarsus. If you have such a thing, for example, this patient who had a tarsal wound, marginal wound, and it was just closed with a simple suture. Of course, the simple suture was opened, and still the patient has the wound as if it is not done. So in such case, you will have to trim the healed skin here, and you have to make the tarsal edges parallel to each other, as you can see in the this picture. The tarsal edges should be parallel, and if the wound is only here, for example, if the wound is 2 millimeters from the tarsus, you have to extend your wound to the whole body of the tarsus till the end, and even you can extend it till the crease. You will take this from the skin and muscle. This will make you close the lead margin in a very nice way, and it will never keep a notch. So the rule for marginal wounds, you have to extend the tarsal wound till the end, till the crease, as you can see here, till the crease, in a pentagon manner, not a triangle. So don't make it like this triangle. No, you will take 2 parallel incisions in the tarsus. Then the apex will be the apex of the pentagon will be in the skin and muscle. In this case, you will get 2 benefits. The tarsal edges will be parallel, so you can close it easily, the margin with the vertical mattress suture, and the tarsus itself with the spatula needle, you close it by 2 sutures. Then the skin, you can easily close it with Vicryl suture, as I told you, reverse cutting or taper needle. And this will closure in such technique will avoid any adhesions or fibrous tissue to the orbital septum and to the orbital rim, which will leave the scar. Here's the vertical matrix suture. You can see it here in this marginal lead wound. I entered here from the far, then in the whole body of the tarsus. And to know that you are in the tarsus, enter the needle in the meibomian gland orifice. So now if you enter the needle from here in the meibomian gland orifice and go deep in the whole body of the tarsus, inside the body of the tarsus, and you come out in the margin, also in the meibomian gland, far. So you entered far and you come out far. Then you take the needle again and enter near the wound and come out near the wound, and you tie your suture here. This will make the lead here everted, and it will never make a notch. The most important, one of the most important things is to manage the canalicular injury. So how the main difficulty in the
دكتور تامر ممكن ثانية واحدة قبل ما تموف النقطة دي. We have a يعني about this is a very nice way to close the marginal wound, but do you advise this rather than doing the 3 suture technique that you take? Yeah, normally we teach that people will take 3 sutures, one in the grain line, one in the meibomian glands, and one in front.
Exactly, Dr. Yahya. As you said, this is the main suture. If you do this suture right, everything is easy afterwards, because this is the main suture which gives which makes the tarsus, and as I told you, the technique to make the tarsus edges parallel to each other and the apex of the pentagon involving the skin and muscle up to the crease here. Once you do this technique, you will close the lead margin. Regarding the second and the third suture you are telling us about now, you can take it here, the second suture and the lash line, and then you close the skin. But this is the most important suture, the vertical matrix suture of the tarsus. This is the most important. If you do it right, don't worry about other sutures.
Thank you. Thank you.
بالنسبة للcanalicular injury, canalicular injury is challenging. Why it is challenging? It is challenging because of the proximal end of the canaliculus, which is lost inside the tissues. We call this end, here is the punctum in this area. This end of the canaliculus, we call it the distal end of the canaliculus, and the proximal end of the canaliculus or the medial end is down here within these tissues. So how can you find this proximal end? The problem that bleeding here is too much. So first of all, you have to dry this area totally. No bleeding, but don't use cautery, because if you are using bipolar cautery, sometimes you will fibrose and you will cauterize and burn the tissues, and you will never find the proximal end of the canaliculus. So first of all, you have to wash it with saline with adrenaline, for example, to make it to stop any bleeding. Thorough dryness of total dryness of the area you are looking for. And the second thing, use a big magnification using the microscope. So at that time you will find here the proximal end, sometimes without anything, you will just find it. But if you cannot find it, how can you use things? What are the tools you can use it to make you identify the proximal end of the canaliculus? First of all, you can inject helon from the upper punctum into the upper canaliculus. This helon is better to be stained with fluorescein, and you inject it slowly. Don't inject too much, because if you inject vigorously, the helon will go into the nasolacrimal duct, into the second nasolacrimal duct, and you will not see it coming out of here. So the tip here, you inject it slowly and look for a bubble. Small bubble will appear here. It will not come as you think that a lot of helon will come here. No, a small bubble, stained bubble, will come out here. So at that time you can identify the proximal end of the canaliculus. The other thing, you can use a tool, an instrument called the pigtail. What is the pigtail? The pigtail, this is the pigtail here, as you can see. This pigtail, you can, there is a hole in this pigtail, and I will show you how can we use it. First of all, you enter from the upper punctum, For example, if the cut is here, so you enter from the upper punctum through the upper canaliculus into the common canaliculus, then the lower punctum, and you go out of the proximal end of the cut of the canaliculus. Once you come out of the proximal end, it is easy to go into the distal end of the canaliculus and out of the punctum of the lower eyelid. Then you put a thread into this hole and then come out with the pigtail again from the upper canaliculus. Now what you have the thread inside the upper punctum, upper canaliculus, common canaliculus, lower canaliculus, which is cut here, and the lower punctum. Then you can put a tube into this thread. You can put the tube into the thread like this. It will follow the thread and it will come out of the second here. Here is the silicone stent, and you can just put it inside this 4-0 proline. Usually 4-0 or 5-0 proline easily go inside the tube. So you thread the this proline into the silicone tube, and you push the silicone tube into the canaliculi till you get it from the other side, and then you tie your suture. So you have this donut tube inside the common and the canaliculus and the canaliculi. Of course, you splinted here the wound. This is a way you can do it for cut wounds into the canaliculus. Another way is also to use the pigtail and also use the thread. As you can see here, the pigtail is from the upper punctum, common canaliculus. It comes out of the proximal end of the lower canaliculus, the cut end. Here is the distal end. This blue area is the distal end of the canaliculus punctum. Here is the proximal end. So you put the pigtail and you come out of the proximal end. Then the thread, you put it through the hole of the pigtail and you get it out, as you can see, from the upper canaliculus. Once you get it out from the upper canaliculus, you can tie this thread around the tube, and then you can bring it through the nasolacrimal duct directly under the inferior meatus, as you can see here, because you tied the thread around the metal probe of the Crawford tube, and then you take it till the end of the nasolacrimal duct. What about the proximal end we want to reconstruct? You put the Crawford tube into the distal end of the canaliculus and get it out of the cut wound here, and then tie the other end of the thread into the tube directly. And then you will bring the thread also again through the nasolacrimal duct. So now the tube is splinting the whole canalicular system. Actually, this is not easy. To tell you the truth, this is not easy. And to tell you the truth, I don't use this technique, but I have to tell you all the techniques and you choose the best for you. Usually I use the monocanalicular tube, and I will show you now. This is the monocanalicular tube. The monocanalicular tube is easy because it has this plug here. So after splinting, after identifying the proximal end of the cut, you can just put the monocanalicular tube through the punctum, the distal end, into the cut canaliculus, into the proximal end, and to put it into the nasolacrimal duct and bring it through the nose. I usually use this, and this is easy because you can do it much easier than using the pigtail and tie a thread around the tube and so on. What is new about identifying the canaliculus is to use the probe, the vitrectomy, not the probe, the light, the endoillumination, the 23 gauge light. You can use it. You can go through the upper punctum into the upper canaliculus and shine the light and put the light of the microscope to the dimmest. You will see the light coming out of the proximal end you are looking for. So this is also an easy technique. As you can see here, here is the cut of the canaliculus, the lower canaliculus, the probe, the endoillumination through the upper canaliculus into the common canaliculus and you start the illumination, you will see the light coming out of the proximal end you are looking for. So now you can identify it. This is also a nice technique. You can do it easily if you have the endo illumination in the OR. Once you do this, you have to know, is the medial canthus tendon is it cut or not? Because you need to, of course, this is a suturing. You need to avoid such picture. You don't want a patient after your surgery coming to you with this traumatic telecanthus. You have to correct this by suturing the medial canthus into the periosteum using, as I told you, non-absorbable suture, Prolene suture, so you can bring the medial canthus to the posterior lacrimal cleft. So as you can see here, the medial canthus is a normal way. So if you follow the rules, you can get this thing. This after I removed the whole fibrotic tissue here in this eyelid and reconstruct the lid so you can get this good picture. The canaliculus cut here, you can see here after doing the same, as I told you, no scars, nothing. You can just see the monocanalicular stent here. This is the monocanalicular. You cannot see any scar in this area. This patient, after removal the whole suture and reconstructing and follow the rules, you can get such a result without any bad scars or these deep scars, because you are suturing the skin, not only the skin, the deeper layers and at the end the skin. This patient I showed you with self-eviscerated eye. I did her the evisceration. I put an implant, reconstruct the upper eyelid, and reconstruct the lower eyelid with the medial canthal tendon reconstruction, upper canaliculus reconstruction, lower canaliculus reconstruction, and brow reconstruction. Following the rules, this is the picture at the end of the surgery. You can get such a result without any bad scars. These small scars is nothing for what you can see. As I showed you before, these scars is very minimal if you compare it to the bad scars of the face. Look to the brows. Once you use the technique of the vertical matrix sutures, the proper sutures, the proper needles, you can put the brows in a very good position. Look to the brows here, they were cut totally. So the eyelid, the contour, it's very important to have this contour. The avulsed lower and upper eyelid, the contour is very important to keep the good look of the patient. So in conclusion, lid wounds is not just suturing. It's not just suturing. There is science behind this suturing. Do it and follow the rules and you will get good results. And at the end, these are my professors and dear friends. We enjoyed our time together for more than 20 years now in different conferences and abroad and inside Egypt. So I hope that we can go back again to travel together and go out again, inshallah, very soon. And thank you very much.
Thank you, Dr. Tamer, for excellent presentation, excellent demonstration.
Thank you so much. And I'm so sorry for making so long. But
perfect.
basic البيزك ده بيبقى صعب شويه، فعشان كده معلش انا اسف ان انا طولت يعني.
لا it's perfect. يعني you covered everything in a perfect way. يعني this is the idea that we want to transmit, the basic principles, the rules. I think all of us have learned a lot, and also all of us are impressed with your excellent skill. يعني perfect surgeon يعني as usual. One question we had it at the beginning just to cover this. يعني some it was about Dr. Dua Ashraf was asking, in facial dog bite, is it better to suture or not?
Of course you have to. انا عندي I have a series of dog bites يعني ما رضيتش اجيبها لان شكلها مخيف يعني، بتبقى في كل حته بقى يعني الشفايف والخدود يعني everything is torn, so you have to reconstruct everything, and these surgeries are very challenging, and of course you have to suture. Don't leave it.
We use tetanus. We give. Should we? يعني this should be a routine. Dr. Mahmoud برضو, if we can add on this. يعني should we give tetanus vaccine for trauma cases or not?
هو usually cases بالذات الدوج بايتس يا دكتور يحيى هم they don't come to the ophthalmologist or the plastic surgeon في الفيرست، يعني بيروحوا دايما الاول مثلا مستشفى الكلب، بيروحوا الاماكن اللي هي عشان العضه بتاعت الكلب، فبيدوهم هم
بيدوهم
الفور
ريبس.
انجكشن.
هل تيتانس
I
يعني
believe ان هم
كلاسيكالي بيتقال ان احنا المفروض ندي في الاوبن وود.
they give them the tetanus and the 4 injections of
Okay. Thank you, Dr. Tamer, very much. And we move on. The Professor Mahmoud Sulaiman, he will give us which is very important thing for all of us and for our junior colleagues, that to know what is the true nomenclature for the trauma, what is the classification of different types of trauma. And this is very important to start the management, the proper management of any case of trauma. So Professor Mahmoud Sulaiman will give us an overview of this, and this is extremely important.
Okay, thank you very much, Turehia, for the invitation, and it's always a pleasure to join you and my dear friend Tamer. Yes, we do really miss our travels together. We used to have, really high quality time together. Well, ocular trauma will shift now to what we call globe injuries. I mean, ocular trauma can involve the adnexa, but what we're going to concentrate now is the topic of ocular trauma. And like many other subspecialties and other topics, the nomenclature and the standardization of the terminology was a real problem in trauma, and ocular trauma in particular. So we have standardization now in diabetic retinopathy, for example. So if you meet a patient who is with a non-proliferative diabetic retinopathy, a mild non-proliferative, you really understand what is meant by a mild. Or if you say that this patient has a proliferative diabetic retinopathy with fractional retinal detachment, this is in a more or less as a very understandable terminology. This was actually very missing in trauma. So now we have a trauma classification, which is more or less standardized, and go through quickly about the nomenclature. And so we know that globe injuries is a very important cause of blindness, and many of these injuries, unfortunately, can be prevented. We lacked a common language for many years, and now we have what we call the Birmingham Eye Trauma terminology, which is called the BET language. And this has been described since 1996 by Kuhn and his co-workers, but it has been standardized by the International Society of Ocular Trauma now. So it has now been endorsed by several organizations, and provides a clear definition of all ocular injuries with different types. It thus puts the injury type within the framework which can be comprehended and can be understood by all dealing with ocular trauma. There's a very important issue about the classification, and we relate to the whole eye globe as the tissue of reference, which is important. And the eye wall, if you're talking about the eye wall, it involves the cornea and the sclera. When we talk about closed eye or globe injuries, there is no full thickness injury or wound of the eye wall, so the eye wall is absolutely intact. Whereas if you're talking about open eye globe injuries, there's a full thickness wound of the eye wall, so the eye wall has been breached. So let's go quickly about the different types. This is a quick summary of what we're talking about. So if you have a full thickness wound of the eye, and this causing breaching of the eye wall, which is again an open eye injury caused by a blunt object. So you had a blunt, very severe injury which has caused an opening or an open eye injury. We call that a ruptured globe. So rupture is not what we used to say that any open eye injury is called rupture. No, rupture is only caused, this is a terminology related to an open eye injury caused by a blunt trauma. Whereas if you have a full thickness wound of the eye caused by a sharp object, again, this is an open eye injury, we call that a penetrating injury. So you have one entry wound which has caused an open eye injury. Well, if you have a full thickness wound of the eye wall with an intraocular foreign body, technically it's an open eye injury, but there's an intraocular foreign body. We call that a retained foreign body. So it's an open eye injury with a retained foreign body. This is the terminology. Whereas if you have two full thickness wounds where you have an entry site and an exit site with breaching of the eye wall, we call that a perforating injury. So if you have a perforating injury, which this will mean that you have one entry, one exit wound. If you have no wound present at all and the eye wall is absolutely intact, caused by a blunt object, we call that a contusion injury. And mind you, contusion injury can also cause very severe visual loss, like choroidal rupture or severe eye edema, or even optic nerve avulsion. If you have a partial thickness wound of the eye wall, still the eye is closed, and we have a closed globe injury, and we call that a lamellar laceration. This lamellar laceration can take place either in the cornea or in the sclera. And this is more or less a summary. So you have one entity, closed eye globe injury, and we have open globe injuries. In closed globe injuries, when you have a sharp, an injury with a sharp object which has not penetrated the eye, so we have the lamellar laceration. In closed eye globe injury with the blunt trauma which did not breach the coatings, you have a contusion injury. In open eye globe injuries, we have sharp or blunt. If you have a sharp which has penetrated, which has caused an open eye, we call that penetrating. If there's an intraocular foreign body, we will call that open eye injury with an intraocular, retained intraocular foreign body. If you have two wounds, entry and exit, we have that perforating. Whereas if you have a blunt with an open eye injury, this is a ruptured globe. There is also a scoring system, which is quite complex. We will not go into this scoring system, which relies on the vision on presentation, the type of the wound, and a scoring system which will give you more or less a prognostic value for the visual rehabilitation of the patient. We will not go into that because it's quite complex. So now, this is a standardized classification terminology. I hope that all of us will be able to use and use routinely in our ocular trauma cases. And thank you very much. So we stop here, and I asked Dr. Yahya to carry on with his presentation on, I think, chromatic cataract and traumatic corneal wounds.
Open globe injury. Okay. Can you stop sharing? Okay, I'll share. Thank you, Dr. Mahmoud. It's very important for all of us to be aware of this terminology. So just want to share. ساعات بيختفي ال اوكي شير سكرين. Okay, thank you, Dr. Mahmoud. It's very important to have this in mind, terminology, because in communicating with each other, we should know the correct terminology so we can have the correct picture about the patient. I'm going to move about open globe injuries. I'm going to skim over the corneoscleral lacerations and traumatic cataract. Usually, as Dr. Mahmoud said, we would say corneoscleral rupture, but as we know now, we talk about, if we say laceration, it means it's an open globe injury due to a penetrating or sharp injury to the eye. So Dr. Mahmoud has illustrated how important and how significant people are affected and losing vision, and usually these people are in the young age group, which is the most productive, and they have the longest lifespan. So it's very important that we really give time in each step to give the best primary care. As Dr. Tamer showed, the primary care is extremely important. The primary management is the most important for the later on effects. And we should also be aware that we have to have a systematic approach to diagnosis and basic surgical principles, because these are crucial to decrease the morbidity of the patients and the later on complications. And we should always, this is the same classification, I will skip it. I'm just going to show the open globe injury here, the full thickness wall of the eye wall. I'm skipping that because this is Dr. Mahmoud has already talked about this. Just a reminder, but you have to remember that the open globe injuries can be caused by so many variant causes, car accidents, dealing with some worker or mechanic, or you are doing home household work, broken glasses in a fight. So many variables can be, and many of these patients, they have multi-system affection. And so when the patient presents, you should assure that there is no other systematic problems like head injury, cardiothoracic, because you have to preserve life first and then you give attention to the ocular trauma. But there are so various causes of the penetrating injuries that you have to be specific in history and evaluation of each case and imagining what the possible damage could happen. And this would not be possible except if you take a proper history and as well have a well or clear understanding of the anatomy of the eye, of the orbit, and you can anticipate what are the structures if you don't see them according to the history of the trauma, the pathway of the trauma, the foreign body or the knife or the glass. You can correlate the history with possible damages and what you are looking for, because as you saw, there are so many different presentations that could be severe and you will not see well. You have to think the different possibilities when you see such patients. And the corneoscleral lacerations can follow blunt, penetrating, or perforating ocular trauma, and perforating means there is entry and exit. And it may be the only injury, it's in the eye or associated with the cornea and the sclera, or can be associated with uveal, vitreous, or retinal prolapse and injury. So you have to be careful identifying the tissues. You should have a complete ophthalmic history and physical examination. And this is very important for the evaluation of the patient, for managing of the patient, and for excluding other life-threatening injuries. The main objective is to determine whether the globe is open and whether there is intraocular foreign body. Open globes should undergo ancillary testing and surgical exploration. But remember, you will never use any pressure on the eye. You will never put eye drops in an open globe injury, but you might need to do a CT in such cases. Remember, there could be other injuries that could be life-threatening. This is very important in multi-organ injuries. This is the classification Dr. Mahmoud was talking about, and we try to apply this in our department, and it's helpful. It is not the best thing, but it's helpful to give a prognosis and to give you, to be more accurate in recording the trauma. And it depends on or categorized, injured eyes are categorized by 4 parameters: the type of injury, which means the mechanism of trauma. عشان كده, it's very important to ask the patient carefully. It's not enough to say that he was hit by a glass. Was it a glass rod? Was it eyeglasses? Was he hit by a bar of iron, or he was hammering some nail? So it's very important, and you try to even understand how what was the direction of the trauma. We grade the injured eye based on visual acuity at presentation. So it's very important to document this, not only to have the prognosis, but also for medical legal importance. Don't avoid doing this. Pupil, it's very important to, if we can see the pupil, to report on it, and the zone of injury. And it is the zones are classified into zone 1. You should write, if you have a corneal injury only up to the limbus, you say this is a zone 1 injury. If it extends 5 millimeter into the sclera, you say you have a zone 2 injury, and zone 3 is a full thickness injury more than 5 millimeters posterior to the limbus. This helps you in recording the type of injury, and also helps according to this ocular trauma score to allow you adding this. It's not very complicated, but you have to be trained to do it. Just you report everything. Everything has a score. Then you will have a score like this. And if you have a low score, it means the visual prognosis, the good visual prognosis, is very low. If you have a high score of the ocular trauma score, it means that you have a high probability of good visual acuity. Saying so, this does not mean sometimes if you have very low score at presentation, like perception of light, if the patient is properly managed, many of these cases could have much better visual prognosis. But this is important for you to talk to the patient, to the family of the patient, and to give prognostic factors for you and for the patient. And we should remember that we might need some diagnostic tests, CT, ultrasound when feasible, ERG in some very rare cases. And one of the main things that we should think of is preventing infection. Any trauma case is a potentially infected case. Whatever you do, you have a risk of infection. So you have to be very careful doing this. This is Dr. Mahmoud will illustrate also how important the CT for the intraocular foreign bodies, and you have to suspect according to the type of injury. You can have an open globe scleral wound, like here, for example. If you have a blunt trauma, a severe blunt trauma by a fist, for example, in a fight, you can have this extensive subconjunctival hemorrhage, but you have to think that there is a possibility of a scleral rupture, which means it's an open globe injury, and you have clues to it. You have to look at the anterior chamber depth. It might be, you can see the pupil is shifted here. So these patients will need exploration to identify if there is a scleral rupture or not, and if there is, and most probably there will be, so you have to manage it. And sharp injuries to the eyelids, as the Dr. showed, can be combined. It can be only in the eyelids, but also they can be combined with severe ocular trauma and injury. So you have to be careful. And sometimes of this trauma, they can be deceiving. This child presented for Asra Ain al-Hawadis when I was in casualty, when I was a resident. And you can see it's a very trivial, it's a child crying, very small lid wound. And if you are lazy or you are afraid to examine the child, or the child is crying too much, so you can just, you might be deceived to dismiss him. But if you dismiss him, you will miss this severe corneoscleral rupture that, if not managed properly, this child will lose his vision forever. So it's very important, the proper evaluation of the patient, starting from the history, the evaluation of the whole patient, understanding the type of the trauma, regardless of the appearance of the patient. So corneal lacerations can happen in a penetrating trauma in different grades, and you have to evaluate and think, always suspect in any penetrating trauma that the patient will have a foreign body. So understand by examination and by the history, what was the trauma with, follow the tracks, look for it. Actually, this is something I learned from Dr. Mahmoud Suleiman from the beginning, from when I was a resident with him, that we should always suspect intraocular foreign, and it's true. Many times you will not see the entry, but you have to look for it. Sometimes it's covered under the eyelid. And at the same time, you have to correlate the findings with the inciting. This is a full thickness wound, but it's warm, small, and it's self-sealing. So here it cannot be I cannot have a huge trauma by a glass, for example, or a knife. It has to be something very small, like a pin or a needle. So, and this, if you evaluate properly, you examine the fundus and they find the situation. This is self-sealing corneal wound. If this patient is adult, well, the instructions, you can just deal with this with a contact lens, bandage contact lens, so as to just keep the anterior chamber formed until this wound heals. But sometimes, as you can see here, the anterior chamber is shallow and it's a larger wound. This wound has to be sutured. In spite of the fact there might be no, most probably there is no intraocular foreign body after evaluation, and the shape of the wound, it's big. So you expect a big intraocular foreign body if there is, and you can see the lens is not affected. Sometimes a glass foreign body can fall in the angle and not see it, but you have to look for it later on or during the primary presentation. This wound has to be sutured. This is not the type of wound that you will leave for contact lens, and this is more extensive penetration of and it's very obvious, the edema, the gaping of the wound, the lost anterior chamber, and usually the iris will just try to clog this opening to keep the pressure of the eye, and this what leads to glaucoma adherent and later on more problems. This is a more extensive trauma that we very frequently see with a knife, with glasses, and this trauma is involved in the cornea and the sclera. These are different examples and causes of penetrating traumas that we can see. It looks drastic, but actually we see any one of us, or at least we work in Qasr al-Aini emergency, definitely you have seen some variant of these types of trauma. As you can see, you have to evaluate, as we said, this is obviously a large object, sharp object, doing this clean cut into the cornea and sclera. The lens could be affected, iris could be affected, iris could be prolapsed. So you have to evaluate the situation. You have to know the extension of the scleral wound that you need to dissect around. So the primary thing is proper evaluation. This patient has this limbal wound due to a sharp injury as well. And you can see the iris is prolapsing. And it's always a common question, what should I do with the prolapsed iris? Always, iris is a very precious tissue. We should always work and try our best to save the iris tissue. It's not immediately we go and cut it. Even if there is some exudates over the iris, you can clean it up, as I'm going to show you. So iris, as much as possible, try to preserve the iris. And there are a lot of ways that we can save the iris and get it. And usually, as a rule, until I go later on, you try to reposit the iris, not from the main wound, but from a paracentesis that is mechanically will allow you to reposit and the iris into the eye without insulting the iris and losing a lot of its pigments. Just I'm showing you so many different examples. And this is a patient that had trauma, and actually this patient refused to do the surgery, and he just escaped. But these are variants. You have to look if you don't pull the lower lid down, you will not see, because see this trauma, because the anterior chamber is formed, the iris is clogging the wound. It's a lower limbus injury, and if you don't examine the patient properly, you will miss this rupture. Again, different similar rupture with more iris prolapse. Always think how to preserve the iris. Always think what other associated ocular trauma is there. As you can see, this is a neglected rupture. There is exudates, discharged corneal edema. Still, don't lose hope. You have to clean this. You have to wash. The first thing you should start when operating with these patients, you should start by cleaning, washing, and then trying to preserve as much tissue as possible. If you don't do the proper management, you will see such complications, severe scarring of the cornea. Although, even if you do proper suturing, you can have a scar, but it will be a neater scar. You can, if you neglect ruptures, you can have infected ruptures like this, and patients sometimes present in that late stage. or like this one, you try to avoid losing the iris tissue, try to avoid making unneeded scars that will make visual recovery later on more complicated. So we just have an idea now, but let's see how we should deal with as a first aid. You should cover the eye when you examine the patient. You should put no pressure on the eye. Extremely careful. You have to press on the orbital margin when you want to open the eyelid. Don't press on the eyelids. No eye drops or ointments in open globe and injury. And usually it's best if it's the patient presenting late, or generally we can give prophylactic antibiotics systemically. And we should prepare for surgery as soon as possible. And we should always try to do it the sooner the better to the more risk of endophthalmitis. We have to always think that these patients are potentially infected. The incidence is high in penetrating injuries of endophthalmitis. With intraocular foreign bodies, it's even more higher incidence. So we should be aware of the area where the patients had the trauma. There could be more than one organism, and there are this list of risk factors. So the history is very important. The history to prevent infection and endophthalmitis is very crucial in all trauma cases. Otherwise, even if you do the best repair, you can lose the eye just because you did not pay enough attention for the possibility of infection. There are certain antibiotics with good coverage and good intraocular penetration that you might think of using it. And this is a list of it, like vancomycin, ceftazidime, intravitreal. If it is at the end of the surgery and closure, you can use it if you suspect more deep penetration of that wound. So you can use this. And oral, like ciprofloxacin, you can use it for 1 week post-operative. So this is adding to what Dr. Tamer said. It's always in trauma, there are objectives. The objectives are, number one, you should restore anatomy. It will be best if you can restore function at the same time. And number three, to restore cosmesis in cases of, like Dr. Tamer showed, and lid injury or even globe injury. So first thing, you have to reposit, you have to know the anatomy to put everything back as much as possible to normal. This might be enough to restore the function, but if it does not restore the function immediately, it will help you to restore the function in a later session. So you have to have this clear in mind. It's not only closing wounds, it's with a clear objective. The surgical repair should have this principle. You should restore normal anatomical relationships and functional architecture, prevent post-operative complications like avoiding hypotony by proper closure, avoiding infection, and preparing for secondary procedure if needed. Generally, in closure of wounds, we want to have a watertight closure, not an airtight closure, because a watertight closure will assure you that you will have a well-sealed wound post-operative. If you have, sometimes the airtight closure is deceiving. Intraoperatively, it will be fine. If it absorbs too fast, you might have a leak post-operative. So as much as you can, you have to obtain watertight closure. The rules, if we have a corneal penetration involving the limbus extending to the sclera, always try to restore the anatomy and make it. The best thing is to close the limbus first, and the limbus should be the first suture in such type of surgery, of trauma. And then you deal with the corneal rupture, and then you look for the scleral rupture. This is usually the logic sequence. And you have to have rules that you want to restore the topography of the cornea if you're closing the cornea. It is not closing, just closing with anything. In these cases, we are using 10-0 nylon sutures. Preferably, wherever you are near to the pupil, the center of the cornea, you have to make as short bites as possible to close the wound and to be able to embed the sutures. The more periphery you go, you can take longer bites. The idea is to keep the topography of the cornea, that it is more prolate in the center than in the periphery. Don't over tie the sutures, so you make a cornea oblate, and this affects the visual outcome later on. And don't do in the center long bites, otherwise the here will scar and will use astigmatism and will definitely affect vision. So you have to decide the type of the wound. Is it lamellar wound that can close easily, or is it an open wound that has to be sutured? And the sutures, again, I'm showing here just to demonstrate what I've just said. You don't want to have an oblate cornea. You want to have, after suturing the cornea, you want to keep this dome of the cornea. You want to keep the cornea prolate in the center, and this not only restoring the anatomy, you are also restoring the function for the patient. And this shows you the central sutures are shorter than the peripheral sutures. And this is the main thing here, is to avoid scars in the center affecting the visual axis, so it will affect the patient. So these are short bites, longer bites in the periphery. And there are rules that we have to stick and understand in closing. If we want to close the cornea, and this is very specific because the cornea is extremely important and we have to repair it properly. You have to be able to coapt the superficial part of the wound with the deep part of the wound. The cornea should be coapted, closed like this, the anterior surface and the posterior surface. So your bite has to be as deep as possible. We avoid full thickness, like in figure C, we avoid full thickness, although it will give you perfect healing, but it risks being a track for infection entering of microbes into the globe. So try to be as deep as possible, as equal as possible in both eyes, including the same volume of tissue, so as to have better healing and less scar. If you do just superficial, you will have posterior wound gaping, and this will give you high astigmatism. And if you just don't include equal bites in a proper way, you're not careful, you can have an edge, an elevated edge posterior, anterior, and this again will induce scar. If you have a sloping wound like this, as in figure F, although from so if your microscope view, you can see the superficial part, it looks as if it is not equal bites, but actually look to the deeper bites, it's exactly the same. So in this way, you can coapt this slanting wound. So you have to be observant, understanding the proper suturing technique to achieve the proper results. Otherwise, whatever you do, how long time you spend in the surgery, you're not going the results that you should get. And this showing you, again, the sutures, how they should be placed, how equal, how deep they are. This is the correct, you never want to have tissue override, whether anterior or posterior. And this is the way to close a slanting wound. You can see posteriorly, you have the same amount of tissue from here and here as well. Sometimes we have bad wounds, and I'm going to give you just an example later on, but sometimes we have very bad irregular wounds that are difficult to suture. You try as much as possible to achieve what we say, like this is stellate wounds. You have different methods, but the idea is again to have them coapted without protrusion or tissue overlight as much as possible, and to achieve water tightness. Again, we're using almost always in our facilities 10-0 nylon, spatulated needle. These are different examples. Sometimes, very rarely we can have tissue defects, and if we have tissue loss, then we might need a part of a tectonic graft or even a sclera patch to close the eye. But if most of the times we don't see this, even in very irregular and severe trauma, so you have to figure out what is the shape of the wound, how say what is the sequence of sutures. You always should look for angles to control. You should look what are the least number of sutures that will give you a watertight wound. And this is very important. And we can use different type of use. This is one case that our resident, very clever resident, have sutured. You can see this, it has a lot of, before, this is after cleaning of the exudates, but you can see it's a long wound, not extended. This is zone 1, not extending to the sclera. There is possibility of traumatic cataract. It means this is a large trauma by a large sharp object, and then the sutures are placed according to the rules, but you have to make sure that you are watertight. And you can see this suture in the periphery is the site of the paracentesis that would use to reposit this iris. And this is the correct way, because if you start to reposit the iris from the center, you might lose some tissue or make it atrophic. And at the same time, usually it will come back. And in such cases, you should look to the angles and you decide what is the plan, how is the sequence. Here, the limbus is not affected much. You can have one suture here, and then you start one suture in the center here in this angle, another suture here, and then you can reposit again the iris, reposit again the iris until you reform the anterior chamber. And many a times you need viscoelastic available with you, definitely. This is a scar related to longer bites, but even such a scar, if some part of the pupil is clear, not everyone will need penetrating keratoplasty. Some people will just improve with astigmatic correction in glasses or hard contact lenses, and you'll be amazed how many patients, if you properly close the cornea, even if you have a scar, they will have very useful vision post-operative without the need for going for keratoplasty. So this is sums I will go through the issue of traumatic cataracts, but this sums the corneous clear, the principles of corneous clear ruptures and how we should proceed. The traumatic cataract may be associated in so many of the examples I have given, but there are some questions to be asked. And this is a very common questions from our colleagues, the residents. Should we operate simultaneously with repair of the open globe injury for the cataract? Should we remove it immediately? And what's the best scenario for managing traumatic cataract? So if we have to ask ourselves in evaluating the patient, we see that there is traumatic cataract. I should ask myself if there is rupture capsule or not. If there is rupture anterior capsule, and this is usually what you are going to see, if you have rupture capsule, you ask yourself if there is, you have to evaluate if there is it opened anterior capsule with no lens matter in the anterior chamber, or there is lens matter in the anterior chamber. And if there is lens matter in the anterior chamber, how much is it? Is it so huge amount that really will push you to remove it? And or is it just many times you have some fluffy material in the anterior chamber? And remember, most of these patients are younger patients, and it's softer cataract, some fluffy material, and many times an anterior capsule can heal by itself. Of course, we'll develop more cataract opacification of the lens fibers, but it's not a big deal to leave the cataract. Don't operate immediately. Don't be deceived by the amount of cortex. You have to really to give it a good thought. Why? Because if you do simultaneous cataract, simultaneous, I mean you have a patient with ruptured globe, open anterior capsule, and traumatic cataract. What should you do? If you repair the wound, this is your first objective, and you will ask yourself, should I remove the cataract or not? Sometimes you have to, but you have to remember the problem of removing cataract. In the same time, it's almost impossible to do proper biometry. You have bad visualization because of edema, the suturing, the cornea. You have anterior chamber stability issues because still it's fresh wounds. You have risk of increased post-operative inflammation because already the eye is insulted from the trauma. And you have risk of infection, as we have already stated. But what about if we do it sequential? And this is in my opinion, this is the best approach. If you can postpone cataract surgery, it's always better not to do this, not to do it in the same time, because you allow proper biometry as much as possible. You give the traumatized eye time to settle down and become quieter, and you give cover of antibiotics and cover of steroids, better evaluation of the situation, preparation for the surgery, plan including iridoplasty. Many of these cases will need iridoplasty. They have a problem in the iris, or they have synechia, or they have a loss of some part of the iris. So there might be other things to do, will not be the best thing to do it in the primary procedure. And there is decreased possibility of post-operative inflammation, and there is better working condition. You are working in a cold case, you have visualization better, the cornea has settled, more clear, you have all the setup is normal, and the presentation of traumatic cataract, as we know, can be variable, different presentations. Even in closed injury, you can have this type of posterior subcapsular cataract alone, or you can have loss of the iris tissue like this. And this is, I think, we should not do this in the primary. We should reposit as much as possible of the iris. Sometimes it's there is iridodialysis, but there is also excision of a lot of the iris tissue. There are different scenarios, like you see here, open capsule, a lot of synechia, subluxation, even you can meet such cases. But again, you try to avoid, and if you wait, like in this case, for example, with an open anterior capsule, if you wait 1 or 2 weeks after repairing the rupture, it will be no real problem. You can cover with topical steroids, cycloplegic for the patients, and usually it is not a severe inflammation as people think if they leave the cortex in the anterior chamber. Just, I want to show you, this is with a revisited, this was sent, already was repaired, and even the sutures were retaken, but in this area it was completely distorted. No sutures, you can see no pattern of the suture, just trying to keep the cornea closed and the watertight. It is not watertight. So in such cases, if you cannot close anything, you can use tissue glue. And to use the tissue glue, you have to dry properly. And then we use the histoacryl with this applicator, plastic applicator, and you just drop on the area of leak. This will seal it, and you can trim the excess of this tissue glue. You can see it will not stick if it is not dry under it. And then you make sure that you have a watertight wound by forming the cornea. There are so many different scenarios. There are so many different scenarios. This is a patient coming with rupture, iris prolapse. You have to wash a lot. And actually, this patient was referred, and the referring doctor said he has cataract, traumatic cataract to be removed. So you have to evaluate, start to work away from the main wound, but because this was like 2 days after the primary surgery, you have to, there are some exudates and synechia. So you have to work through the wound and use excess viscoelastic, trying to dissect the synechia at the angle and at the back of the cornea, because this is, as I said, it's not the same day, so a lot of exudates, fibrin. So you should make all effort to release these adhesions. The first suture at the limbus, and usually pass, you hold where you pass the needle. In the other area, you're doing counter pressure to have the needle passing. Hold where you're going to pass as deep as possible. First suture for the limbus, counter pressure. Go out and then tie the suture. This will reconstruct the cornea. suturing 10-0, you can have it, if you do it in this way, you have 3, 2, 1 knots. The first throws, these are called approximating knots. Then the second two are tightening knots. This is where you make the maximum tightness. And the third one is locking knot, which you will not be able to tighten more after you did this locking knot. Opening then the conjunctiva to see the scleral extension. Of course, because this was a small bite, so I took it. And as we said, the rule, essentially, we go finish the cornea and then go to the sclera. And then you try to look for angles to suture. And then closure of the conjunctiva with an embedded knot. Always make sure to embed the knots. Now you can see what was confusing for the referring doctor of cataract. It's obvious for me, this was an inflammatory membrane, exudative membrane. So I started to dissect it, injecting viscoelastic using a Kruger or a push-pull hook, just pulling it and dissecting it in the anterior chamber. You can use a micro forceps in such case, and then I can see then that the lens is completely clear and is not affected. So all I did is removing this membrane. If I leave it, it will create synechia. It will make recovery much, much more difficult. Later on, you need more treatment. It will take long time to absorb if it absorbs. You can see how the membrane, and usually these membranes form very fast in young children. You see, cleaning the anterior chamber. So you have to work step by step, following the rules. And then you try to get the iris and the pupil as circular as possible and to avoid any adhesions of the iris to the back of the wounds. Another example, this was a small, دي كانت ست في المطبخ في علقة اتخبطت. She had a corneal wound, small corneal wound, because it could be left unsutured because it was almost self-sealing, very small. But if you are doing cataract, then you have to use it because still it's fresh. It will open. It will not withstand the pressure inside the eye. And then you start to work as a normal cataract, but always keep in mind that you have a possibility not only of opening anterior capsule, but also posterior capsule opening. So you have to be careful in doing all the steps. Here it's a mature cataract or total cataract, intumescent. You stain, you do the rhexis, very careful. Irrigation aspiration is phacoaspiration essentially. You decrease the height of the bottle because you can anticipate posterior capsule rupture. I just want to, you see, already. You have to evaluate the posterior capsule if there is any opening. Anterior vitrectomy, you can do the anterior vitrectomy if you have the 23 gauge from pars plana. But if you don't have it, you can do it from the anterior wound with high cutting rate. You can see the vitreous. There's vitreous strand here. You have to be careful not to leave any vitreous strands in the anterior chamber, because once you have passed this properly, you can implant the lens either in the back or in the sulcus. And here is the best is the 3-piece lens to be implanted to assure that the lens is properly centered. This is a child, repair trauma, 2 weeks post-operative, anterior capsule open, some cortex there, iris, posterior synechia, anterior synechia at the corneal wound. So you follow the rules. Staining of the capsule that you know it's open. Dissecting the synechia, posterior synechia, using a lot of viscoelastic. Then with the scissor, of course, you can use micro scissor. I saw there is an opening, the anterior capsule is already open, so I make an edge to be able to do a capsular access. And on the other side, at least you can assure at least half, the lower half of the rexis is continuous. To be able to do irrigation aspiration, it's a soft cataract. And still, you have to think there is a probability that posterior capsule is open. Viscoelastic, in such cases, use viscoelastic as much as possible. You can see here the anterior capsule. The capsule is intact, so again, I will do a snip in the anterior capsule. And then we'll continue into a more circular part. And this is washing the posterior capsule, remove any epithelial cells. And because this is a child, you don't have to do the next step, but everything is quiet and clean. And this is an advantage of the sequential surgery that you can do. Because it's a child, definitely it will have opacification of the capsule. I chose here to do a posterior capsular access, injecting viscoelastic through a small opening in the posterior capsule, pushing away the anterior vitreous face because I don't want to lose vitreous. And then doing a posterior capsular access to ensure a clear visual access post-operative for this patient who suffered severe trauma. Following the rules again of the posterior capsular access, then you can inject and see if it's wise to inject in the back or not, checking the remnants of the pupil, any cortical material present, and then the best lens to be implanted is a 3-piece lens. You can implant it in the sulcus. In such case, I choose to implant it in the sulcus. And I'm just showing you here that you have to be very slow in unfolding the lens. You have to make sure that the leading haptic is going where you want it, either in the back or in the sulcus. And then let the lens unfold slowly. You don't want any jerky or sudden movements. Otherwise, you can extend the tear in the anterior capsule or even go through the posterior capsular access. Then you fill the anterior chamber with viscoelastic and make sure to rotate the lens in the plane behind the iris and to make sure that both haptics are resting in the sulcus to avoid any decentration of the lens. And the key in this is proper viscoelastic in the anterior chamber, preserving the pressure in front of the IOL and behind it, pushing the vitreous backwards, and don't settle until you are sure that the lens is properly positioned. No, don't just put it and run away and you say, okay, this is enough. No, you have to make sure, but you have to know what you are doing and you're not insulting more tissue. Then after implanting the lens in the proper place in the sulcus, then I'm now dissecting the synechia or adhesion of the iris into the old corneal wound.
دكتور يحيى,
You have to be careful. أيوة.
Do you prefer here to do an optic capture يعني ولا to put the whole lens in the
sulcus, because the anterior capsule was not continuous. There was a anterior capsule.
Okay.
But if there was not, then I would do this.
يعني لكن in case if it is the anterior capsule or rexus is
I will do optic capture.
Okay.
Now, after releasing this, the iris, which is very important to release it, I'm doing a rhinoplasty in that area using Prolene and using the 4th rows sutures, 4th row 1 suture, Prolene 10-0, better 9-0. Then you can see the pupil is getting round, and then I'm revisiting this wound because the suture, the primary sutures was not good. So I'm releasing the iris. You can see still some of the iris tissues here. And then I'm taking sutures just to make sure that this wound will be closed tight. And this is the way embedding the tissue before the suture, before cutting the suture. This makes it easy for embedding of the 10-0. And then I took a suture in the main wound because of fear of hypotony, and this is a child. So in this way, you can manage much better if you do it sequentially, the surgery. So this will, I will just skip this one. So in conclusion, all trauma cases are unique. Optimal management often requires creativity based on a solid understanding of the pathophysiology and surgical approaches available. Thank you for your attention.
Dr. Yahya, I need to ask you a question, please, Dr. Yahya. What يعني which method you use for البايومتري بالنسبة لل last case اللي هي الطفل اللي عنده corneal scar وهتحط له IOL يعني هل do you prefer a certain type of biometry formula or photography?
Actually, in such case, when you have mature, you cannot use, if you don't have IOL master, the regular one will not work. So it's an ultrasound biometry, and that's why and you try to see the curvature. We do topography also to see the astigmatism, and then we ask the biometer, the one who's doing the biometry, to check also the K readings on the other eye. We prefer to use the K readings of that eye, but sometimes if the sutures are too tight, it's too flat, and you don't want to have the biometry on that basis, otherwise you will be overcorrected.
But you don't prefer or you don't recommend to do secondary implantation. Do the cataract first, and then maybe later you can do a biometry after healing and do secondary implantation?
Normally not, because you don't want to
leave the child amblyopic.
This is one thing, and again, to avoid opening the eye again, because this has suffered trauma and then did another surgery. So if you can implant immediately, it's best. Otherwise, if you have severe corneal scar that you know is anyway, you will never be and get good vision, then you can leave the patient affected, because many of these patients probably will need retinal surgery afterwards.
Okay. Dr. I have some questions for you, just for. So if you have since we're talking about penetrating ocular injury, I mean, if you are faced with a corneal wound which is self-sealed and the lens is clear and the anterior chamber is clear, would you opt for a suture, or you leave the patient to heal, or the corneal wound to heal alone?
If I will use contact lens if the patient is probably above 18 years old. Younger patients, I will take a suture. Yeah. Or if a younger patient and I see him responsible, we can use a contact lens and see him next day, every day until it's healed. But for young patients, it's better to take a suture. It's like the children, we have to take a suture.
So do you wash routinely with antibiotics?
In any type of surgery, intraocular surgery, I inject intracameral antibiotics. Usually, like
moxifloxacin.
Moxifloxacin. And in trauma cases, I wash with the antibiotics, and at the end of the surgery, I inject intracameral antibiotics.
Right. Okay, so I just want to endorse some of the points you mentioned. Yani, number one, I absolutely agree with you. You have to preserve the iris. You have to really work very hard to preserve the iris. And even if you have some adhesions, iridocorneal adhesions after the surgery, you can go in a second sitting and just sweep and remove the adhesions, and this will really help the whole structure of the eye. The other thing is that, yes, I do agree that when you're dealing with these patients and you have a problem and you have an open lens capsule, you have to be prepared with a cutter, a vitrectomy cutter, because if you really have an open posterior capsule and the lens matter is there and you don't have a cutter, then you're really in a mess. And you leave the eye in an explosive formula. So you really have to, if you're operating these eyes, you really have to have a cutter which is prepared.
Thank you, Mahmoud. We move now for the last but not least, the best presentation of the day. Dr. Mahmoud Suleiman is going to talk about intraocular foreign bodies, which we see a lot: khartouche, gunshot, rush, خناقة, مسمار. We will see in all types of intraocular foreign bodies. So that's why it's very important lecture that we know how we should proceed in such cases. When should we operate? What should we do? How should we think?
Okay, thank you very much.
The best to say this lecture is Dr. Mahmoud Suleiman.
Thank you very much, Tariqia. Well, it's my pleasure, and we'll take you for in a completely different turn, and we're going now to really take a dive into the deep sea of the vitreous and the problems with the vitreous. Well, intraocular foreign bodies are, we said, as one of the entities of open eye injuries, with a special feature is that we have an intraocular foreign body retained in the eye, and these patients need some special management. Okay, so let's talk quickly about the epidemiology. It forms about 20 to 40% of patients of ocular trauma. It varies whether you're in industrial areas or not. Age group, as Dr. Yeh has said, the problem is that usually it's in the younger age group, this is the working age group, and it has such socio-economic impact. Males are usually those, I mean, most of the patients are males. Female retained foreign bodies are usually very rare. Although now we see more females with the pellets and the gunshot injury. So what important is, what are the natures of the foreign bodies? Usually they are metals, and these are the commonest: iron or steel, copper, lead, different alloys. And now occasionally we see the stone and sand in blast injuries, particularly those working in the quarries, or war injuries, glass due to car accidents. And sometimes, rarely, we see organic intraocular foreign bodies related to plants or some of the organic injuries. In most of the cases, this is related to hammering. So the patient comes to you and he says that I was hammering and something flew part of the stone. Actually, it's not part of the stone, it's part of the hammer itself, or enduring machinery. So he's using a high velocity machine, and a small piece of what he's cutting just flies and hits the eye. Car accidents, actually, unfortunately, we see a lot of foreign bodies due to car injuries related to the not using the belts, the seat belts. Now it should be routine. Sports, occasionally, someone is working or playing squash or something, you hit the eyeglasses and the eyeglass breaks into the eye. Very occasionally, we see domestic injuries from an explosion from a Coca-Cola or a bottle of a gaseous liquid, and blast injuries. And now we see a lot of, unfortunately, gunshot injuries. So very important things you have to understand about the pathophysiology of damage in intraocular foreign bodies. And this is the size of the foreign body. So the size of the foreign body will determine the amount of the tissue damage insulting the eye. So if you have a patient like this, this is one of my old patients, and this is, what is this? This is a patient who came to me and he said that something just jumped, I was hammering and something jumped into my eye. The eye was showed a lacerating wound or a perforating injury, but when we did him a CT, you found a huge nail. Obviously, such a big foreign body or a huge foreign body will cause a very severe ocular injury. Or this is a rubber bullet which has penetrated the eye. Obviously, the tissue damage is huge compared to an intraocular foreign body, which is small like this. This foreign body, obviously, the amount of tissue damage compared to this is really minimal. What is the nature of the foreign body? Is it a metal? Is it iron? Is it copper? This is important because it will decide and determine the reaction of the ocular tissues. So this is a patient of mine who, as you can see here, this is a plastic foreign body. This is acrylic, but the eye is absolutely quiet because this is an inert substance. Whereas this is a patient, and you can see there's siderosis, so the iron will incite a reaction. What about the site of the foreign body? The site of the foreign body will also affect the reaction of the eye. Some tissues are more prone to incite a reaction, like the iris or the anterior chamber. The ciliary body can cause a severe reaction, whereas in the lens, the reaction is quite little. Vitreous, it will slowly decompose and cause degenerative changes. If the retina is affected or the foreign body is impacting the retina, there is a reaction, but it can be tolerated. Infection, as Dr. Yahya said, is important, and it can end up with the loss of the eye, not from the trauma, but from the infection. And intraocular foreign bodies, the organism, these gram-negative organism, Bacillus cereus, is usually the pathogen, and infection can reach about 15% of intraocular foreign body, despite the fact that you think that this is a high velocity, yet it's not sterile. It can harbor some infections. Specific effects, we quickly go. Siderosis, you all know about siderosis, and these are nothing but a decomposition of the ferric ions of the iron intraocular foreign body, which is deposited in the cells, causing interruption of the cellular activity and cell damage. So all the epithelial cells in the eye will be affected, including the corneal epithelium, the corneal endothelium, the capsular epithelium, the retinal pigment epithelium, the ciliary body epithelium. All these cells are going to be affected. In calcosis, which is related to a reaction to the copper, this usually incites a very severe reaction, like this patient of mine who this is a presentation. He was operated, and he had a very severe reaction. I decided to go and clean, and what do you think? I I discovered a very large copper intraocular foreign body in the anterior chamber, which when removed, the eye really quietened. So what do we do when we face a case of intraocular foreign body? There is a dictum, زي ما الدكتور يحيى قال, he mentioned before, intraocular foreign body should be suspected in all cases presenting with ocular trauma, particularly if they have an unexplained uveitis. When you're faced with an intraocular foreign body or a presumed intraocular foreign body, you have to spend time with the patient. You have to take a very meticulous history, and you spend time asking the patient the extreme details of his trauma. What was he doing? What was he doing exactly? What happened? Because this will give you an insight. Most of the patients feel that, no, I mean, this was something hit my eye and it was removed and there's no. Usually when you take a proper history, a meticulous history, you get into the more or less a presumed diagnosis. And then we come to the ocular examination. And if you examine the patient properly, usually you find the stigmata. There are signs of the foreign body, which I'll show you in a moment. And one trick is that you quickly try to dilate the patient. Why is that? Because usually if you have the patient presenting early on, you may be the first one to see the intraocular foreign body before the cataract takes place due to the injury. This is the slide showing one of my patients. This is the site of entry here in the cornea. These are the telltale stigmata which you look for. So there's a small entry site, self-sealed, the anterior chamber is formed, and then you have a small iris injury, and then you have a total cataract because of the traumatic cataract. So you need, if you have a patient which is presented early on, you can examine the patient before the ensuing of the cataract. Sometimes the cataract may progress very quickly and you will not able to see the foreign body like this patient who was quickly examined, and you can see the foreign body. The best thing, the best way to localize the foreign body and to really diagnose the foreign body is to see it. So if you see the foreign body, you know where it is and you really plan. An important thing, if you can't localize the foreign body visually, is to do a CT scan. And this is really the milestone and the hallmark of the diagnostics in the management of intraocular foreign body. So a CT, and you have a coronal, either do axial and coronal sections, and this will show you where the foreign body is. X-ray detection is just for detection. It will not show you the localization. I do not really rely on ultrasonography, with all due respect to Dr. Temer, except rarely. I rely on CT. MRI is totally contraindicated in metallic foreign bodies. If you have or suspect a glass foreign body or an organic, you may, but usually MRI is contraindicated, and I'll show you. So this is a CT scan of one of the foreign bodies. This is one cut, this is the other cut. So this foreign body here is in the nasal, lower nasal retina, is rather posterior, and you know when you're going where to look for. It's intraocular, it's not extraocular. And this is the ultrasonic, so you have a high frequency. And sometimes with a particular, if you rely on the ultrasound, it can mislead you. I would prefer doing a CT. So all patients with intraocular, with ocular trauma, particularly with open eye injuries, should have a CT. So, okay, so you localize the foreign body. We know there's a foreign body. It's probably metallic. You have done the CT, you know more or less where the foreign body is. What to do? Well, there's a dictum. Again, intraocular foreign bodies are ocular emergency, yes, but you should not manage or try to manage before the proper evaluation. So you don't go and schedule the patient for surgery unless you have properly localized the foreign body and you have properly prepared all your instrumentation in order to go through with what you're going to do. And this is what our objectives will be. زي ما قال لنا, as Dr. Yahya just mentioned, the objectives are very clear. Optimum wound closure with restoration of the ocular architecture. Yes, we have a wound there and it needs to be closed. So the number one objective is to close the wound. Occasionally, the foreign body or the patient with the foreign body presents to you after being closed, the wound have been closed and everything is ready. But if you have a wound in the first presentation, you really have to close the wound. If the wound is very large, you have to close the wound first and then schedule the patient later on. If you have a very small wound, you can suture the wound like Dr. Yahya did in his phaco, in the traumatic cataract. If you have a small wound, you can close it and go on with your next step, which is the intraocular foreign body removal. And we'll state now in a moment how we do that. And then, which is again very important, is to prevent infection. Prevention of infection comes by, number one, the very, very early intervention to remove the foreign body, because the foreign body can incite an infection in no time. So you find the patient who looks absolutely quiet eye, and in 24 hours, you have a completely different situation with a very nasty infection. So prevention of infection by early intervention. What do we do? What is the standard treatment now, the management of foreign bodies? So the standard now is to do a vitrectomy with a removal of the intraocular foreign bodies. You have variety of instruments to do that now. It's very controlled in most cases. You can remove the posterior hyaloid if you do the surgery properly. And if the patient has any retinal problems or any retinal injuries, you can deal that with those injuries during the operation or removing the foreign body. What about the instruments? So you have a variety of instruments and foreign body, intraocular foreign body removal instruments. You have to have a variety of sets ready because of the different sizes of the intraocular foreign bodies. You have very large, sometimes, intraocular foreign bodies, which necessitates using, unfortunately, those instruments dealing or designed to remove very large foreign bodies are now not in the market or not in commercial use. Grace Haber used to have a very large foreign body removal forceps, but it's not there. You might need to improvise, and I'll show you in a moment. So another important, very important instrument which you should have ready is the rare earth magnet. And now we have a rare earth magnet, which is a 20 gauge rare earth probe, and you can remove the foreign body using the intraocular rare earth magnet, which bimanually you can manipulate the foreign body with ease. So let's go through. So this is a typical case of intraocular foreign body where you find a corneal wound, a lens injury with a small iris injury, and a retained intraocular foreign body. And let's see how we do that. So the first thing is to remove the cataract, and usually this is straightforward. So in this patient, the lens was removed. There is a posterior capsular small rupture. You can implant the lens if you remove the lens meticulously. You can implant the lens properly in the bag in most cases. If not, you can put it in the sulcus, and then you go back and try to tackle the intraocular foreign body. Occasionally, you have a vitreous hemorrhage, and this patient has this intraocular foreign body impacted into the retina, causing some hemorrhage. The macula is fine, the optic nerve is fine. The moment you see that the optic nerve and the macula is okay, you really are you are relieved. So what we do now is that we did a laser barrage around the intraocular foreign body, which is now surrounded by an inflammatory reaction, and bimanually you do an indentation remove the intraocular foreign body. And this foreign body, by the way, was a copper foreign body. So you open the trocar, remove the trocar, increase the size of the sclerotomy, and out you go with the intraocular foreign body, and close the wound, do air fluid exchange, case closed. The eye is fully restored. The eye now, by the way, this patient regained absolutely full vision. So the patient got back to 6/6 vision this is the dream case. So this is the not the routine. Each foreign body has its own scenarios, and we'll go through special situations. So not all patients or all intraocular foreign bodies are so straightforward. You have some difficult situations. What about if you have an inert, uncomplicated intraocular foreign bodies, like the one we saw early on with an absolutely inert intraocular foreign body, no reaction? Should you leave it? No, you should not leave it. You should remove it. What if you have a subretinal intraocular foreign body? You really have to do a retinotomy in order to get that. What about very large foreign bodies? What about intraocular foreign bodies with infection? How will you deal that? What about opaque media, so that the corneal wound, a very large corneal wound, or the vitreous has a very dense vitritis or a vitreous hemorrhage? What about dealing with patients with siderosis? If the patient has a long history of a foreign body which has been neglected, should we operate? We'll see in a moment what we do that. So this is one case, and you can see this is a cataract. And in this very lucky patient, what happened is that we found that the intraocular foreign body was impacted in the lens, and it was easily removed during the phaco, and you just remove the cataract. This patient, during evaluation, we knew that he had an anterior intraocular foreign body, but we thought it was impacted in the ciliary body. Actually, it was not. It was impacted in the equator of the lens, but we were fortunate, and the patient was fortunate. It was removed during the phaco, and you just implant the lens, and the patient is back to normal, case closed, everything is fine. Another patient here, this is a typical, this is a patient with a site of entry, cataract here. The foreign body is, as you see here, is hanging in the vitreous cavity. The retina is normal, the macula is healthy, the optic nerve is healthy. So what you need is to remove the foreign body here using different techniques. This patient, we elected to remove the wire. It was a wire in the anterior chamber, and you just place it in the anterior chamber. Then you go open, remove that. This is one way of removing these wires. There are other methods, which we'll see in a moment. So this is another patient here, which had a vitreous hemorrhage. And when we removed the vitreous hemorrhage, we knew that there's a foreign body here. We realized that there's a foreign body impacted under the retina. So we had to do a retinectomy in order to get access to the foreign body. And you do you do the diathermy, do a retinotomy, and we realized that there's a huge foreign body here. This is a huge wire. How did it get into the eye? Is a big question mark. You remove that bimanually, and this is why in all cases of intraocular foreign, all cases of vitrectomy, I urge you to use the chandelier. Look how big the foreign body wire, which has been impacted under the retina was attached, and of course, what you do here is to do a laser photocoagulation to the retinotomy or the retinectomy, and leave the patient with silicone oil. And this patient, after that, was. What about infection? This is a case of intraocular foreign body and we had an infection. This is a clear infection. You remove the vitreous membranes. This patient, we knew that he had an intraocular foreign body. Using the CT, you need to clean the vitreous cavity. We did not realize that the patient actually denied any sort of exposure to gunshot injury, but this is not a very nice situation that the pellet falls on the macula. But look, this pellet was removed using what? Using a toothed forceps, because it was too big for any forceps to remove. And this is what we call the improvisation of using instrumentation. Sometimes you really have to think and how to remove that, and we'll see during the presentation different times. Sometimes you have to be careful that in blast injuries in particular, you might encounter multiple intraocular foreign bodies. Like this patient. This was a single-eyed patient from Yemen, and we was in for either was and membranes, and which was removed. It was, I think it was copper. It was a blast injury, and then there's the second one, another one here. During vitrectomy, you need to examine the eye very meticulously. This is one, and then another one which was impacted. This is the other impacted. You might think that this is over, and actually it wasn't. In the moment you see that when you're finishing your vitrectomy, you notice here this reaction. This is a rather unusual reaction here, and what happened is that this is another third intraocular foreign body. During vitrectomy, if you can remove the posterior hyaloid, as I just mentioned, it would be good to do that. For removing the posterior hyaloid will avoid the patient developing any fibrosis or any epiretinal membranes. You do laser photocoagulation around this area, and in a moment, using bimanual technique, indentation from one side, you remove the foreign body. This is another foreign body here, and this is using the cross-action lens implanting foldable forceps. Remember that this is a forceps which I got from an old cataract box, and you have to, because it's crisscross, it holds the intraocular foreign body quite hard and quite meticulously, so you're able to remove that. This is how we use that. So you go in using this crisscross action, and you grasp the pellets and the intraocular foreign body. Well, siderosis is another problem. So this is a patient who had a siderotic eye. He was not diagnosed, unfortunately. You have to look for the signs of siderosis. This patient had a telltale. This is the site of injury, and he had a membranous cataract, partially absorbed lens, and this is the typical finding in the vitreous with vitreous membranes due to the reaction from the intraocular foreign body, widespread retinal pigment epithelium because of the toxicity from the retained intraocular foreign body. And in a moment, you're going to find out where the foreign body is. This is the foreign body at the extreme periphery of the retina. You clean that and you remove the intraocular foreign body using forceps. These patients with siderosis, siderotic eyes have a severe inflammatory reaction, and you very frequently meet the epiretinal membranes, which should be removed during surgery. This is the same patient a few weeks later on, and actually the vision with time reached about 0.2, and these siderotic eyes regain or recover vision with time. Another patient here with the typical siderotic, the siderosis bulbi, seen on the lens capsule and on the cornea, and you remove the cataract, again, the vitritis and the very severe reaction, and the foreign body is hanging in the vitreous here. This is not bad quality recording. This is due to the severe siderosis, which affects the corneal clarity. The foreign body lies down there, you remove the foreign body. I'll show you in a moment. You can use bimanual techniques. You remove all the vitreous, shaving. And this is a trick. You can use the rare earth magnet and put it on the shaft, and you end up like a magnet, rare earth magnet, if you don't have an internal rare earth magnet. So remove that under control. This is a very controlled removal of the foreign body, and you remove the trocar. Again, this is another trick. This is the rare earth magnet. When you're removing the intraocular foreign body, you can place the rare earth magnet. I'm showing you this in particular. Why? Because during removal, I realized that the sclerotomy was too small. So with the other hand, immediately you increase the size of the sclerotomy. You wouldn't like the foreign body to fall down, and put the rare magnet, the rare earth magnet on the sclerotomy, which helps you not to lose the intraocular foreign body. Okay, another foreign body, remove that. Another siderosis. This is a siderotic eye, a typical siderosis. I'll just show you where the intraocular foreign body lies, a typical siderotic patient, and we actually did not find the foreign body. We found that the foreign body in the subretinal space, and this in particular patient, this patient had the intraocular foreign body in the eye for maybe 2 years. This patient recovered 0.1 vision with time. Okay, another intraocular foreigners which we see now these days are those patients with the pellets, and usually the foreign bodies or the retained intraocular foreign bodies, which are pellets, are accompanied with severe vitreous hemorrhage. As you can see here, this is the usual picture when you're operating on these patients, very severe vitreous hemorrhage, and the foreign body or the pellet is entangled in the blood in the periphery of the retina. The retina is detached. You remove the foreign body or the pellet using the crisscross action in order to get a proper grip. By the way, when you're operating on these patients, this patient had a macular hole, and you're operating on these patients, these foreign bodies or pellets have different calibers and different sizes, so you have to be ready. Another patient here with the pellet, you put some PFCL in order to try to get it away from the macula. I don't use this anymore now. I use Helone in order to protect the retina. And when you protect the macula, you go in and remove the pellet out. Okay, so this is quickly to show you that you're able, this is a patient with a very large corneal wound which has been sutured maybe a week earlier, and the patient has a vitreous hemorrhage. Will you be able to do your work in the presence of this scar or corneal wound? Yes, you're able to do that using the biome system or the wide field system. You're able to do that, and you're able to remove the vitreous hemorrhage, and the visualization is really not bad. So this patient had, after cleaning the vitreous hemorrhage, you do that bimanually. This is the flute needle, and you put the shaft, the long axis of the foreign body in the intraocular foreign body forceps, and this patient we removed it from the anterior chamber using the assistance of the rare earth magnet. Another patient here, and then this is the last patient. Again, stigmata of the intraocular foreign body hitting the cornea and the iris and the lens, and you remove the cataract. Carefully, you implant the lens in the sulcus, in the sulcus, and in you go. The foreign body is there. By manual manipulation of the foreign body, and out you go with the assistance of the rare earth magnet. Okay, so what about intraocular foreign bodies? As I mentioned earlier, it has to be suspected in all cases of ocular trauma. There is a wide range of instruments nowadays which are required, and you should have them ready if you're operating on these patients, because each intraocular foreign body is a different case in itself, with different sizes, different material, different tissue damage involved. Bimanual surgery, I always like to use bimanual techniques. This is easy now using the chandelier, which is I use in all cases of vitrectomy, particularly important in cases of intraocular foreign bodies. Late complications are not unusual. Retinal detachment is a possibility, particularly if you have to need to increase the size of the sclerotomy. Sometimes you end up with some sort of a retinal dialysis. Please check the retina periphery after removing the foreign body. Macular epiretinal membranes, if you do not remove the posterior hyaloid. Again, the issue of sympathetic ophthalmia, it is there and it can happen. And we've seen patients with sympathetic ophthalmia, and the incidence is variable from 0.2 to 2%. Their visual results in intraocular foreign bodies are actually the best in open eye injuries. But they are influenced by, number one, the size of the foreign body, which determines the tissue damage, the site of impact. If the intraocular foreign body hits the core, hits the optic nerve or the macula, of course, the vision will be affected severely. Is there an infection? Infection, of course, will definitely be detrimental to vision. What is the timing of the intervention? Because this will decide whether there have been toxicity from the material or the foreign body. What about siderosis? Well, if you find a patient with siderosis, do not give up on him, because the vision can slowly recover. Like this patient I've shown you, and so many patients I've actually operated with siderosis, and with time they regained quite good vision. So at the end, if we're talking about intraocular foreign bodies and ocular trauma as a principle, as a whole, it needs imagination. You have to be really imaginative, because each ocular trauma is different from the other. It needs dedication. Sometimes you have to operate under stressful conditions, and it needs passion, because you really have to sometimes operate on these patients several times. And thank you very much.
Thank you, Dr. Mahmoud, for comprehensive, excellent presentation with the varieties, all varieties. One question, just to make it clear, what is the time frame? What is the latest for an intraocular foreign body, and what is the earliest time to interfere? If you have a vitreoretinal surgeon, should it immediately with the repair of the rupture, or is it after 1 day, 1 week? What is the time frame?
Yes, very good question. It depends. It depends on the size of the wound. If you have a very large wound, like one of the cases I imagine, you will not be able to do both procedures at the same time. It's impossible to do a closed vitrectomy with the pressurizing of the globe, with pressurization of the globe. But if you have a small wound, you can take a suture and operate. Actually, most cases are referred or present maybe a day or two after the event. But if you have a patient who presented on the spot early on, one thing you have to evaluate, as I just mentioned, you have to properly evaluate, do a CT, see where localize the foreign body, prepare your surgery under favorable condition, have all your instrumentation ready. Do not try to enter without having a proper preparation of all instrumentation, the forceps, the rare earth, because you might need any of those, and you'll be in a real problem if you don't have any of those. So with a small wound, you can maybe operate, the sooner the better. It is not an emergency which you really have to take the patient directly to the operating theater. No, you prepare yourself. If you have 24 hours to prepare your things, you can do it in the following day with the favorable conditions. But mind you, you have to have a very, very close follow-up with the patient, because patients can, as I just mentioned, in few hours go into infection.
Okay, thank you. But also there was a saying in older times that you should wait for posterior vitreous detachment to happen, because usually these are young people. So if you do the vitrectomy, then it's more risk to induce retinal break. I don't know if this is correct or not.
No, this is now unacceptable, absolutely unacceptable. This was related to earlier animal models which were presented by Steve Ryan on rabbits on open eye injuries. And now we do not follow these. In intraocular foreign bodies, you have to prepare the patient, and the sooner the better. You have to operate as soon as possible. To avoid infection, this is a very, very important issue. There comes the issue of antibiotics. Will you give the patient antibiotics until you operate? This is a very controversial topic, and it was never, up till now, any proper studies to determine whether you need to give the patient intravitreal antibiotics.
اوكي ثانك يو دكتور محمود. سؤال اخير للدكتور تامر، احنا خدنا وقتنا وزياده. دكتور تامر, in the canalicular repair, you said your preferred method is using the mini monocanalicular stent. So what type and size of suture do you suture the canaliculus, or you don't suture it and leave it on the stent?
Okay, thank you, Dr. Yahya, for your great videos and great lecture. Thank you, Dr. Mahmoud, for the very illustrative lecture. I actually enjoyed them very much. Regarding your question, Dr. Yahya, about the suturing the canaliculus, whether you are using a monocanalicular stent or bicanalicular stent, first of all, you have to close the margin in the way I described, the vertical mattress suture. Then, because usually here the margin is affected in these cases. The second thing, you take two sutures, one above the stent and the other one below the stent. So you don't need to suture the canaliculus itself. Just take a suture to approximate the tissues above the stent, because now the stent is inside the canaliculus. So once you are taking, for example, 7/0 vicryl suture above the stent and another one below the stent, now you are sure that they are approximating the tissues. And then you close the skin and the subcutaneous tissue. If it is a big wound, you have to close the subcutaneous tissue first, then the skin.
Okay, thank you, Dr. Tamer. Thank you, Dr. Mahmoud. I think we thank you, Eva Pharma, for helping and putting this symposium or webinar together.
Yeah, thank you, Eva.
Thank you, Dr. Mahmoud. Thank you, Dr. Tamer. Thank you for everybody for attending.
Thank you very much, Dr. Yahya, for organizing this webinar in a very important topic. And this is not the end of the trauma, because there are many aspects of trauma. This is just an introduction.
كده بسيط. يعني فعلا this is an introduction for trauma. If you are going to speak about trauma, you can speak many webinars, but yeah, I think it was very, very comprehensive webinar. I hope everyone benefit from this.
This is the most common cases that the younger colleagues see in the casualty, and they have to take decisions or manage. So that's why I think this is useful to have to start with. Then the more sophisticated trauma is later on.
Later, inshallah.
Okay.
Thank you so
much. Good night. Thank you.
Good night. Enjoy.
Pharma.
Thank you, Muhammad Hassan. Thank you, Andrew Wahid, for sponsoring this meeting. Thank you, Dr. Yahya. Good night.
Thank you, dear
Bye,
Professor.
Dr.
Thank you.
And of course, thank you for the audience, for all the attendees. Thank you.